Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease.
You're all very welcome. Today we're talking to Dr. Tom Karlsen, who is the chair of the upcoming PSC conference, which is going to be held in Phoenix in October. For more information on that, please go to www.pscpartners.org. We're also discussing the latest breakthroughs in research. Welcome, Dr. Karlsen.
I'm Tom Karlsen, and at the core of what I'm doing, I'm a transplant hepatologist. So I work as a senior consultant in the Department of Transplantation Medicine at Oslo University Hospital. I also have a university affiliation through a full professorship of internal medicine, which involves all types of academic activities, research, teaching, etc. I'm also the research head of one of the clinics of the hospital, which is now called the Clinic of Surgery and Specialized Medicine. It's a fairly large clinic with more than 2,000 employees and 35 research groups. So there is also some administrative duties to my overall portfolio. And of course, I remain involved in various international professional organizations. Currently president-elect of the Biomed Alliance, which is an umbrella organization of various medical associations in Europe, and also serving the EASL Journal of Hepatology. So it's a mixture of work, but patients at the core, and the hepatologist standing the reason why we're talking today.
You also have an expertise in primary sclerosing cholangitis in Oslo, don't you? You have some grant funding, and it's one of the sort of centers for research.
Yes, as part of the research portfolio, really the main activity of our own research, or my own research, is on primary sclerosing cholangitis. I've worked now on PSC for more than 20 years. And that sort of aligns very nicely with this 20 years anniversary of the conference that we're visiting, because I've seen the PSC Partners throughout this entire career. And this has been an entity which has been growing. We had some philanthropy support coming into the system around 2007, 2008. At that time, we were three persons working on PSC in Oslo, but there had been a long preceding history of research on PSC in Oslo dating back to the 1980s. But with additional support, we were able to grow the center, which currently comprises more than 40 people fully dedicated to PSC. It's spread across 3 different research groups with independent group leaders, and I'm trying to strategically coordinate and align all those people and all those projects.
So you're the chair of the PSC Partners conference this year that's coming up in October.
Yes, exactly. So I'm fortunate to be co-chairing this meeting together with the PSC Partners, and I've been working with the PSC Partners to set up the program, trying to make a little bit of a mixture of, cutting edge research results. What are the news? What do you wish to know about the ongoings in the PSC research field? In addition to more basic topics that is of relevance to patients and caregivers. And I think that the program is a little bit a mixture of this, the more on the basic knowledge, and also the research agenda as it currently stands. So this is a big honor for me, and I've, as I said, been following the PSC Partners over the years, working with Ricky Safer on various instances, having attended previous conferences, which I have been very much impressed with, which is also part of the reason why I accepted to be on board for the program this year.
What seems really interesting to me is just that with 40 people doing dedicated research to PSC as a disease, that's got to be the largest PSC research in the world.
In many ways, it's the biggest single aggregation of PSC researchers in the world. And I think, we're covering also the most comprehensive portfolio of projects. We're running basic projects, mouse studies, almost, basic science aspects related to disease pathophysiology, all the way up to clinical applications, clinical implementation, clinical trials. So we're covering basically the whole translational journey of discoveries in PSC, which in many ways we had to do because the unmet needs in PSC are so large. There are knowledge gaps all the way from basic understanding to clinical tools. So for us to only focus on one kind of research was not sufficient if we were to kind of try to transform management and understanding of the disease. So we have to cover everything, and we felt we had to cover everything. That said, we have had some sort of a shift in orientation over the recent years from the more basic understanding pathophysiology research into clinical applications. And I think within our current 10-year horizon into which we are now 2 or 3 years advanced, the overarching vision is that there should be a clinical footprint of what we do, that our research should change clinical practice, and there should be new tools, there should be therapeutics applied in clinical medicine coming from at least partly our research. But of course, you're part of a bigger international scene, and I think it would be worthwhile to also discuss that separately. But I think from our side, it's been important to cover basically everything, and then slowly shifting more towards the clinic as time goes by.
What are some of the sort of breakthroughs or areas that you're most enthusiastic about at the moment?
At the moment, I think the main areas where we are seeing breakthroughs is in the understanding of the gut microbiome in the disease. We have several very specific findings of relevance to disease development, which even have therapeutic implications. One example is the vitamin B6 deficiency, but there are also other features of the bacteria which are important for disease development, which we will discuss further in Phoenix. Also, regarding the immunology of the disease, we are getting closer and closer to the specific drivers and the mechanisms involved, specific cell types, etc. That seems to be reasonable also in terms of opportunities for drug applications, therapeutics. And of course, I think also as part of our own shift, this way we are doing clinical trials in PSC has been evolving. This has been a big headache for not only the academic researchers, but also the pharmaceutical industry, that we have not really been very good at performing clinical trials in PSC. It's a difficult disease. It's a super difficult disease. So new biomarkers, new ways of assessing the efficacy of drugs, the severity of the disease. We have, I would say, put a lot of emphasis on that, and there are both a lot of recent data having come out, and there are more data to come out on that topic. And there are also very important clinical trials delivering data over the next 1 or 2 years, which may actually lead to medications being officially licensed by the regulators and within reach of patients. And
would these medications be treating particular aspects of the illness, or would they be treating the illness itself?
I think, this is a very interesting question, also almost a philosophical question. I mean, because there is the distinction, I think, between halting the disease or making the disease slower and maybe even stop disease development. That's the one aspect. The other aspect is what also is embedded in the PSC Partners mission, this cure aspect. And I think the medications that we now will be probably see arriving over the coming 5 years are in the category of slowing the disease progression. I don't think we are yet at the stage where we will see drugs which will cure the disease. And also, I think you don't necessarily need to fully stop the disease process to make a benefit for patients, because as long as you can put a break to the disease so that it almost does not really evolve, you can actually prevent liver transplantation, which I think is the first thing that we wish to achieve in this disease. We want to stop seeing PSC patients on the transplant waiting list. And I think with over the coming 5 to 10, 15 years or so, we will see drugs and combinations of drugs that I personally believe would be able to achieve that, at least partially. When it comes to a cure, it's a difficult topic. I think to fully cure or to achieve a full stop in PSC development, you need to know the cause. That's also why we have had in Oslo always a great emphasis on seeking the cause of PSC. Because if you find the cause and you can eliminate the cause or control the cause, then certainly you would be at a much more radical opportunity in terms of stopping the disease, even curing the disease, at least from earlier stages. But there is a lot of activity in this space for the first time, I would say, in many, many years. So it will be an exciting coming 3 or 5 years from now to see these drugs. Yeah.
That would be kind of like what's happened with PBC, wouldn't it? That the it's not completely cured, but it's halted enough or slowed down enough that people don't need, or a lot of people don't need transplant.
I think it's a very good analogy, and I think that's where we want to be with PSC, because as you say, PBC patients now on the waiting list are becoming rare, and more. And I think it's the same situation we want to get to first with PSC, that we actually can slow the disease to an extent that patients don't progress into a need for a liver transplant. But then, of course, ambitions shouldn't stop there. We should also be more ambitious and possibly even be able to identify the driving causes of the disease and potentially stop it. But that's, I think, level 2 of the achievements.
Yeah. I'm going to ask you to do something that you probably won't want to do now, but in terms of the 100-foot view of the breakdown of what you're talking about. So we know that there is a link between the gut microbiome and the damage that subsequently occurs to the liver. Can you talk a little bit about that? Do we know what the link is at this stage?
The way and the concept that we are working is a little bit this seeing the bacterial community in the gut as some sort of a biochemical factory. And this biochemical factory produces a lot of nice things, both for themselves as a community, but also for us as hosting this biochemical factory. However, amongst those thousands and potentially hundreds of thousands and potentially millions of chemicals that this biochemical factory produces, we believe that there are some chemicals that may actually not behave so nicely in the bile ducts of PSC patients. And those are the needles that we're currently seeking in this biochemical haystack. And we have some candidates, and personally, I think if you think about the cause of PSC, which we already discussed, I think it's very likely that the cause of PSC is probably residing with some of those chemicals coming from this biochemical factory. But it goes far beyond just mere leakage of whatever waste you might perceive to be in the gut. It's more of a biological phenomenon. And
I think the analogy, maybe that when we talked before, I think the analogy we were talking about is kind of like an orchestra, isn't it? And the string section is off, but the orchestra, so the tune is coming out, but not quite right half the time.
And certainly, that was also a big emphasis over the years for us, particularly in the early stages of PSC, of the Oslo PSC Center. There is a variable genetic background. We are all genetically different, and you may say that on some unfortunate instances, there is a mismatch between what this biochemical factory in the gut is doing and the genetics of the human who is hosting this factory, and it's in this mismatch disease arises, and in this context, biliary injury occurs.
That's why it's more prevalent, say, in Norway than it is in maybe. Well, do we know that? Is it more prevalent in Norway than it is, say, in Italy?
Yeah, there is a gradient. The gradient partially follows also that of inflammatory bowel disease, which is also more common in the Northern Europe. So whether it's entirely due to genetics, I don't think it's we can fully say that. Of course, there are also environmental differences in diet, etc. A topic which is in many ways, I would say, underexplored in PSC. There are some ongoing activities to try to map more closely the link between diet and the behavior of PSC, but prevalence of IBD, genetics plus probably some dietary factor is responsible for these differences. And I know that there are also data coming out from the International PSC Study Group that there is also a quite large differences on the risk of cholangiocarcinoma in PSC.
One question I have on that, is the research in PSC having a knock-on effect on, say, ulcerative colitis or Crohn's?
Yeah, it's a difficult question. I think, what is certainly clear is that many of the things that we investigate in PSC are, general problems of the Western world: autoimmunity, inflammation, risk of cancer being increased associated with inflammation, the role of the gut microbiome. So there is a lot of, transfer value of the insights that we gain in PSC. That said, I think there are so many indications that PSC and also IBD in PSC is something a little bit different from classical ulcerative colitis and classical Crohn's disease that I think also on the side of the cause, it's likely to be something distinct and different than that of IBD. But certainly the context of also the inflammatory bowel disease, pieces of the pathophysiology is related to changes in the gut.
I'm one of the 20% that doesn't have ulcerative colitis or Crohn's currently, touch wood.
I think it's an important point also because we always discuss that whether, PSC with IBD is different from PSC without IBD. Certainly for some people without IBD, you would have like a little bit of a totally different disease. But I still think that the majority of the patients we denominate as having PSC in the West, meaning Europe and the United States, they actually at least have a propensity to develop also some inflammation in the bowel and might develop inflammatory bowel disease, but not always. I think it's the analogy is like, with other inflammatory diseases like rheumatoid arthritis, which affects the joints. I mean, sometimes you have affection in one joint and other times you have affections in another joint or all joints. And I think a disease, the disease that we call PSC is in many ways still the same, despite these differences in or variation in clinical presentation. And I make that point because there's also the discussion that, okay, PSC is so many diseases, it could be like a variety of many entities. I personally think that most of what we see as PSC in the West, even without IBD, is still part of the same disease category as the PSC disease with IBD. It's just that in those cases, luckily, there is not much of a bowel problem
Yeah.
So I think it's an important reflection, and I think we've seen also from the genetic studies, microbiome studies, everything points to the fact that with or without IBD, it still looks the same at the biological level. And
In the liver, yeah.
mm,
Yeah. Actually, just the other day, there was an announcement about a new drug, Volixibat, that was showing early promise for reducing itching fatigue in PSC and PBC.
there are several categories of drugs currently, showing promising results. I think one big bulk of drugs is related to bile acids and how bile acids are being metabolized, synthesized, and is circulating throughout the bile ducts and the liver and the gut. The bile is normally, recycled. It's being produced in the liver, goes with the bile into the intestine, then it goes from the intestine back into the liver, and is being recycled many times a day. So I think, um, this is where this particular drug that you're mentioning comes into play. There are other drugs as well in that same category that tries to basically stop this circulation of bile acids, um, and certainly it's one compound, and absolutely, as you say, particularly for patients with itching, it might be a very nice armamentarium to the toolbox. But there are also other drugs in this kind of bile acid circulation, bile acid metabolism category, which are very promising. There is, we will know later this year, maybe by the time of the conference or just afterwards. Unfortunately, there is the NOR-UDCA or norocolic acid trial by Falk Pharma. They will have the readout of what we call a phase 3 trial, which is like the last trial you do before you go to the regulators and ask for approval of a drug. The phase 2 trial, which is like the earlier stage research on that compound, was very promising. And then we will just see what it looks like. And there are also, drugs like bezafibrate, which has been very popular in PBC and which is currently also being investigated. It acts probably during, a variety of mechanisms, but also partially by interfering with bile acid synthesis and bile acid homeostasis. So I think within that category, there are several promising drugs. And then there are other categories of drug where things are a little bit more immature and a little bit more uncertain, but where there are certainly also exciting developments, like for the antifibrotics. There is much activity for inflammation, anti-inflammatory drugs. I think it's more difficult. It has been surprisingly challenging to identify drugs that actually improve PSC by making inflammation less aggressive. You would somehow expect that, for instance, some of the drugs that we use for IBD would be effective in PSC, but unfortunately not really yet. They seem to be. And reason for mentioning also these different categories of drugs is that probably, if you look at, putting enough brake to the disease that we want to stop transplant risk in the future, you might even need to do more than one category of drugs. Maybe you want to both work on the bile acid homeostasis and maybe alleviate and reduce scar formation, fibrosis, and so I think what we're witnessing at the moment is like the first generation of drugs that will tell us a little bit of what can be worked. And then, as also we have seen now for PBC, you will see combinations, different compounds being used together and thereby increasing efficacy and improving outcomes.
Well, you've answered the question I was going to ask. It's basically so the slowing up of the disease, if you like, of PSC will probably come from a combination of these different
treatments?
Yeah, you may hope, of course, that one drug would do it. I think maybe you could also see it the way that for different stages of the disease. I think one problem that we also have with the drug therapies in PSC is that we are diagnosing PSC too late. This is something we have been also quite interested in Oslo, trying to find their PSC at very early stages where there is very little scarring, very little damage to the liver. And of course, therapy in that setting might differ from what you would do if there was a lot of scarring, a lot of fibrosis, a lot of strictures. And so maybe you would even have different types of regimens for early versus late stage PSC. But I think realistically, and also looking at the signals that we've seen from the early phase trials in PSC, it's more likely that there will be a combination of compounds than just like this one wonder drug, at least in the first arrivals. But we will also learn from that, and then there will be second generation, third generation. So over the years, I'm optimistic that we will have increasingly effective both single drugs and combinations.
The question I had there was that the markers that you would look for, they're not blood biomarkers. Is it possible to find a blood biomarker, for example, for PSC, or is it much more complicated than that?
No, this is a very important question, and I think it's the question that we also get asked by the regulators like FDA and EMA, because they say, okay, we need to know whether the drug works, and how can we do that? So far, we've been very reliant on alkaline phosphatase, which is one of the normal liver tests that we often use in PSC. It's very unreliable in PSC. It's quite good in PBC in many ways because it's a much more stable disease. PSC is like, going up and down. And so alk phos goes up, goes down. You never know whether this is because of the disease or because of something you do, which makes it exceedingly hard. What we have been mostly emphasizing in the Oslo research is the biomarkers in blood, which reflects the scarring and the fibrosis in the liver. Some may be familiar with some of those tests, like the ELF tests, the ProC3 test. There are also other fibrosis measurements. And for me, looking at the liver disease in PSC with the scars and the fibrosis, it's very logical that if you want to show penultimate efficacy, you have to stop that scarring. So for me, it's very logical that the drug that actually works in PSC should be doing something to the scarring, which penultimately should be reflected in the fibrosis tests. And these are becoming better and better. Then comes the question, okay, what else is there? There is inflammation, there is the impact of the gut microbiota, and one of the ongoing projects, which maybe Johannes Hov, who will attend the Phoenix meeting, will talk about, is how can we combine biomarkers for different aspects of the disease into like compound biomarkers. So it will be like multiple biomarkers reflecting different aspects of the disease and jointly giving you a quite precise reflection of what's going on in the liver. I think that's next generation biomarkers, as we mentioned, next generation of drugs going from single to combinations. And I think maybe we have to go there with the biomarkers as well. But certainly, I believe that blood-based biomarkers is something which we will have to understand better, and probably where we will see the efficacy signals of the first drugs arriving. But ultimately, of course, you also want to see improvement in images, in MRI images of the liver, etc. But these changes typically come much slower, so they are much harder to use in the clinical trial context, and it's likely like what you would be looking for once you start prescribing any successful drugs in the clinic and following patients then over the years. Yeah.
And back to the kind of microbiota thing. I mean, there's Klebsiella bacteria that's associated with the disease. Are there others now that you have discovered?
when you're talking about the microbiota, there are different perspectives to take to that. We already mentioned leakage. We already mentioned this biochemical factory, and these biochemical compounds, they are typically produced by many types of bacteria, so it's not really linked to a single bacteria. That said, there are also like these potential bad guys within the bacterial community that seems to be coming up in many studies over the recent years. One is Klebsiella pneumonia, which has been pioneered very much by a Japanese group. They did these discoveries, and this has later been confirmed in other reports. We also see that in Norwegian materials that particularly patients with severe disease seem to associate with the Klebsiella. So this bacteria seems to be doing something, and then we need to understand what is this bacteria doing, and then trying to correct that. There are also other bacteria, Enterococci, which are quite common bacteria. They seem to be enriched in PSC, particularly in patients that have received antibiotics recurrently for cholangitis, etc. And in many ways, judging data both from the US and Europe, again, these bacteria seem to associate with poor outcomes in PSC, both when it comes to Enterococci in bile, but also in the bowel. The third kind of bad guy candidate is a bacteria called Veillonella. It's a bacteria that actually lives from some byproducts of inflammation related to nitrogen metabolism. And so whenever you have inflammation, if you have inflammatory bowel disease, if you have whatever inflammation, there will be more of this bacteria. And this is what we in bacteriology typically call an opportunist. It uses an opportunity that is generated by the host, and then they become more. That said, they are, repeatedly observed in the context of PSC, and even though it's increased mostly because of the opportunity, it could also be doing something, and this is what we're trying to work out at the moment. But I think this is work in early phases. It's a little bit analogous to the work that we did with the genetics. We found the genes, then of course you need to understand what are these genes doing, and then ultimately you can start doing something about it. So that's where this research on these so-called pathobionts, that's the kind of the name of these bad guy bacteria, they're called pathobionts. And it's a very interesting avenue of research from which we will hear very many exciting news, I believe, over the coming years.
This is all fantastic. I could sit here all day. It's just, but I know your time is limited. Just going back a little bit to the conference. So are you presenting any particular papers at the conference that you can talk about?
I think the task that I've been given in the program is very much that of giving an overview of these 20 years of PSC research. And I've already started, reflecting upon how to do that. And in many ways, the perspective that I will be taking in my presentation is actually this movement of discovery and the time and the effort involved in, transforming a disease and its management in medicine. There are some analogies. For instance, in liver disease, there is the example of viral hepatitis C, where you discovered the cause, the virus. 25 years later, you could cure the disease by eradicating the virus. And for me, it's an example not only of the tremendous efforts, because there was a lot of research going on during those 25 years, but it also tells you that it's not something that you necessarily do overnight. So my question that I would say is, so having now witnessed PSC research for 20 years, where are we? And where are we in this kind of timeline of discoveries? And what is the time to be expected in terms of, the big innovations to arrive in PSC? And I think for many of the aspects, we have made good progress, and we are close to seeing clinical implementation, be that of tests and even of the first generation of drugs, as we already spoke about. For the more radical aspects in terms of stopping and curing disease, I think we still have some way to go, and I will be trying to make some projections. So I would rather take this bird's eye perspective and exemplify on what happened during those 20 years and what are the priorities going forward than talking about very specific single projects. We will have many experts from all over the world, and they will be joining both the research workshop, which will be the day before the patient conference. So they will be discussing their research with each other during the Thursday. And I will be part of that meeting as well. Then there will be very detailed discussions on all the projects, and some of those experts will also remain in Phoenix and stay for giving presentations of selected work at the patient conference. And when we built the program with the PSC Partners, of course, we tried to select the experts that we knew were doing the most exciting things and could present the most exciting results. So I think that the total program with the different speakers will give a pretty good overview of whatever is happening in the PSC field at the moment.
So I guess the question is, are we at Newton or Einstein, in terms of physics, you know what I mean?
I hope that we are some way down the road, and I think we are. And I think that's also why it's been nice to be part of this journey over the years. I mean, also within our discipline as hepatologists and in medicine, PSC is increasingly recognized as, an important research topic and an important entity for research, as many other diseases are being, cured, hepatitis, vaccines, etc. So if you look, for instance, at the medical conferences, there was now just a couple of weeks ago the European Liver Congress, and the fall there is the American Liver Congress. If you went to these congresses 10 years ago, even, you would be lucky to find one scientist there working on PSC in a corner somewhere. Now you have big discussions in the big rooms and much more of a balanced representation. And honestly, that's also been part of what I've wanted to do in some of this more organizational work that I've been involved in to make hepatology as a discipline and at least in this more organizational manner to cover all areas of hepatology, including PSC. So from being a bit of a marginalized, rare thing, even when it comes to research interest, PSC is now part of the priorities in the liver research field. And I think PSC Partners have been witnessing and being part of driving and fueling this development. I think we should also give them credit for that.
Yeah, but it's wonderful, isn't it? Because it's yourselves in Norway. There's stuff going on in Toronto. There's stuff going on in Brigham Young Women's Hospital, at the Mayo Clinic, at the so there's a number of large, and even the NIH, or I don't know how their research is going, but they were going to do a large scale PSC study.
No, I think and that's one group which is very close to my heart, because I was part in setting it up. We started it in a meeting in Oslo. It led us to collaborate very closely, and from those genetics collaboration, we built this international PSC study group. And over the years, this has broadened in terms of thematics and topics. There have been meetings in Hamburg, Amsterdam, at Yale. And this year we're meeting in Stockholm in September, just before the PSC Partners meeting. And attending that meeting is basically everybody. Something that even from the outside, people, I wouldn't say they envy us that, but they I think it's something very nice that we've achieved in the PSC research community, that it's a very friendly and collaborative community. And of course, important part of that is also that what we realized in setting up this group, there are so many things that needs to be done. So we cannot afford that two people are doing basically the same thing. which can happen in science for numerous reasons, including competition. This we cannot afford in PSC. We have to work together, reduce redundancy, and collaborate. And this has been achieved over the years, and is a function of I would say mentality as much as strategy. So it's a very nice community to work in as a researcher.
Is there anything you want to add?
No, I can only say that I'm really looking forward to the meeting in Phoenix. It's very important also from the researcher perspective to meet with patients and discuss with patients and have input to patients. What are the important priorities? What are really the big problems? Where should we focus our efforts? That's the one aspect of it. The other aspect is that it's an important part of our motivation. Science is a lonely business, late nights, evenings, at your computer or in the laboratory. So for us to meet with people who are actually interested in what we're doing, which mostly our friends and families are not, right? Talking about this rare liver disease, they're all fed up with it. So for us, it's a privilege to be able to meet with people who actually enjoy listening to us talking about our favorite topic. So I look very much forward to the meeting in Phoenix and to being with all the patients. All the previous meetings I've attended with the PSC partners have been very stimulating and rewarding.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.